Hello everyone, my name is Conor Patterson and I'll be moderating this discussion prompted by the launch of the Ireland's Future document, An Opportunity for a World-Class All-Ireland National Health Service for All. I chair the Daisy Hill Future Group, which emerged out of a shared concern about how healthcare was being delivered to people in South Armagh, Mid and South Down and Newry City. I'd experienced the effects of a health crisis that's affecting us all personally, and that's what drew me into this cross-party, cross-sector effort to secure change for the better. In the last year, as someone from outside the health service, as a consumer and a taxpayer, I have learnt a huge amount. And I've concluded that health service managers are not part of a grand conspiracy to diminish healthcare and dupe citizens. They want to do well, but they are constrained by lack of resources. And I think the real issue also is that they're having to confine their work and the parameters of the options which they can evaluate to a space which is a very small geography. Tied to working into the confines of that small space and its very small population of professionals, they've had very little opportunity to reconfigure systems as business would, and in fact has done, in a broader geographical context to secure economies of scale. So if you take Daisy Hill Hospital in Newry as an example, it has always been measured in terms of the numbers of patients and operations that it can deliver against half of what is its hinterland in actual geographical terms, the half to the north of the hospital. And the half to the south has been largely ignored, and the unmet needs of health needs of populations residing there. And the mirror of that has happened in Dundalk and Monaghan and right along the border. Large towns and a city whose location in terms of political geography has disadvantaged them hugely. At a time of workforce shortages and exponentially increasing demand across the island, I believe we need to look towards much greater sharing of resources between these two systems on this small island. That's why I have become part of the debate which Ireland's Future is seeking to promote. Not as a pipe dream, but as a necessity to improve the lives of people of all cultures, religions and orientations living in this small island in the Atlantic. So I'm delighted to be joined by two people who are hugely experienced and internationally recognised health service professionals, Mairead McAlinden and Dr. George O'Neill. I'll introduce both of them to you now. Briefly, Mairead is a retired health service chief executive, previously working in Torbay and the South Devon Foundation Trust, and known to people across Northern Ireland, I think, in the health service very well as the previous chief executive of the Southern Health and Social Care Trust. She was a ministerial appointee to the Bungoa expert panel advising on future arrangements for health and social care in Northern Ireland, and she currently works as an independent management consultant. And Mairead is also a member of the aforementioned Daisy Hill Future Group. Dr. George O'Neill is a retired general practitioner who's been out of clinical practice now for 2 years. He qualified in 1971 and was in practice since 1974 in a partnership with 5 colleagues in West Belfast, working with an extended primary care team until his recent retirement. His interests included improving mental health services, addressing life inequalities, and developing a wellness service. He was a first wave GP fund holder, an executive member of the Northern and West Belfast Total Purchasing Pilot, and he chaired the Belfast Local Commission Group for 6 years. He was also a GP appraiser for 10 years. Until it was incorporated into Inspire, he chaired Addiction NI, a community-based charity providing support and treatment to people affected by alcohol and drug addiction. And until his retirement 2 years ago, he was joint chairman of the West Belfast Federation of Family Practices, and he chaired the WBF BHSCT multidisciplinary team pilot. So we have two hugely experienced people from the Northern Ireland healthcare sector with us this evening. And to open, and thanks for coming and having this conversation with me, Mairead and George, why do you think a conversation on the challenges and benefits of integrating the two health systems on this small island is necessary now? Mairead?
Sorry, go ahead,
George.
Well, look, thank you very much for allowing me, for giving me this opportunity to describe my views on what should happen. The paper that you referred to, I've read it. I got it about 10 days ago. And really my concern would be that what we're doing is we're joining up two failed systems. We really have to stand back and look as to exactly what we want or what is needed. Now, for what we have is we have a dysfunctional system, certainly in the north, which I've experienced. And I also have to declare a conflict of interest. I'm a service user now, so I want to make damn sure that the system works and works appropriately. But certainly it is failing the population at large. And this has been the case. And if you look at what the reasons are, lack of leadership, performance management, and no external assessment of what we're delivering. So this gives us the opportunity to come together and start a discussion about what we want, first of all here, then we look at the other side of the border, and the discussion has to happen there also. There's good work happening at present in cardiac surgery, pediatric cardiac surgery, some kidney transplants, hip and joints. So there's work happening already. And the other problem we're doing is we are losing our young consultants to the south because of the better pay there. So there's a whole plethora of things that we have to deal with. And the first one, I think, is leadership. We also need a system where there's one person in charge. And the only way you're going to do that, in my view, is if you remove politicians totally from the system. Now, politicians will be involved, like the police authority, where the chief constable has absolute authority over day-to-day management of what happens. His feet can be put, or her feet can be put to the fire at the policing board. You can do that by the health board. Politicians will sit on it. You can't overrule what they're doing. What you can do is you can sack them if that's necessary. And we almost had this in 2005 when Sean Woodward was the Secretary of State, and he appointed David Sisling to run a regional health authority. We almost had one person in total charge of what was happening. A population of 1.8 million does not justify a children's hospital. It isn't big enough to deliver all the quality services we need. And even if we look at the bigger island, the population there is still quite small. And we also should be looking across to the bigger islands beside us, Scotland, Wales and England. For example, if you get involved in transplants, if you have a bigger pool of donors, you're likely to benefit more people. So there's a whole plethora of things that have to be dealt with. And it's not just going to be easy sitting down and saying, we'd like to do this, A, B, C. We've got to have a vision. So what's the vision? What's the agreed vision? How do we deliver the vision? Who's going to be involved in it? What do we want for our population? And remember, we don't have a health service. We have a treatment or an illness service. It's reactive. It doesn't respond, it doesn't pick up, it doesn't intervene. 7 billion is spent here annually on health and social care. It delivers 18% of your health and well-being. 18%. All the other determinants that decide your health, we ignore, or they're not involved. So there's a lot of work to be done on both health systems.
Thanks, George. Mairead?
I think your question, Conor, was why now? Why do we need to open this debate now? And like George, I mean, we've been through how many reorganisations of health and social care, all aimed at delivering better outcomes. And yet, as we sit here, and I've just come from a meeting in Dublin this morning, both our systems are struggling with long waiting lists, recruitment issues, And yet our medical professions, and I hope you'll agree with this, George, are constantly striving for more and more centralisation so they can have larger teams and better expertise, because that's where the evidence is driving us to. The honourable exception to that, of course, being our general practice service, which stays very local, very focused on that population, and is the key driver for health and well-being within that population, I believe. So why now? I think post-COVID, we are absolutely in recovery mode. It hasn't gone away. And a lot of the things that we did well during COVID, we are in real danger of forgetting about and losing. And one of the things we did do well during COVID was to collaborate north and south of the border, as well as you say, George, with the other parts of the UK. And there was a real coming together because it was a crisis. And certainly in my experience, the only way that we come together for that all-Ireland discussion is in a crisis, like when paediatric cardiac surgery collapsed in Belfast through a workforce issue. But I agree with George. I think we have to get in the front foot and be a little more proactive. And when we had a recent meeting in Uri, we talked about synergies. So where are the things that if we come together and collaborate, the sum of the whole is greater than the parts. And there are so many examples of that where we know that we are supporting fragile services with less than optimum workforce, and yet we can't cast our eye wider and say, could we think about this on an island basis, or, as George says, as a UK and Ireland basis? Because that does happen. I mean, there are people who travel enormous distances, get on planes, get on boats to get the treatment that they need. But that's the elective care. There's a crisis there, no doubt, with long waiting lists. I see the greater crisis is in our unscheduled care, our emergency demand. And I believe that that's where George is right. We are really failing people. You know, people turn up, wait a long time for an ambulance, they then turn up and wait a long time in an emergency department, and then if they need admitted, they wait a long time for a bed. And when they're ready to be discharged from hospital, they wait a very long time for their package of care to get brought home safely. So we do have a crisis. We have a health service, both north and south, that's probably not working to its full potential.
Well, why is that?
Well,
Why now?
Well, I mentioned COVID. I think COVID was in some ways very good for the health service because it brought us all together, and it you know, everybody responds well to a crisis. But during that time, all of the non-essential services basically had to be stood down to respond to the COVID effort. So our theatre staff started working in intensive care, and you know, all of those things happened, which slowed the pace of how we normally respond to the normal health and social care needs of our community. But I also think there's another crisis, which is an absolute workforce crisis in our community. So, like George, I have relatives who are service users. And, you know, our domiciliary care workforce is the most undervalued asset that I believe we have. And they do enormous good work, and they keep an awful lot of people out of hospital. But that's not an attractive job for, you know, our young people. So there are multiple crises. So just to summarise, we have a workforce crisis, we have a financial crisis, and we all listen to the budget for Northern Ireland and how we have to pay back what we overspent last year. And I also think we have a population crisis. We are making very little impact on the health and well-being and the needs of our population right now. And again, COVID has exacerbated that. So I think we are at a crisis point, and we talk about that in the health service all the time. It's a very overused word, but certainly looking at the waiting list that I saw today, north and south, we are in a very different place than we were 2 years ago.
And can I just add, we also have a service which hasn't changed its method of delivery in over 100 years. You think of all the things that you use, the banks, education, your mobile phone, everything has changed and developed. Lloyd George, who invented the first insurance scheme, if he came back now, he would recognise the system, GPs, community, hospitals. And our focus tends to be on the sexy, high-profile hospitals, when really, if you want to get a bigger bang for your buck, you should be looking at health promotion, disease prevention. Of our budget here, we spend less than 2% on health promotion and disease prevention. To me, that seems totally illogical. We don't look at patient encouraging the expert patient, allowing the patient to manage for themselves. We ignore carers, and you think of the number of carers who are out there who are not rewarded in any way, looking after loads of people, and yet we do not reward them or support them. We've got to look at it a different way. We don't look at the population. We don't identify those who are at risk and then move in and try and intervene. All of these things are possible, but we're not doing it. Why are we not doing it? Because we're happy sitting in the old system we had before. And if you look at general practice, when I started off in general practice, you dealt with acute, episodic, curative illness. People come in, you treated them, they went. Lots of the chronic illnesses that we now deal with went to the old medical outpatients. Medical outpatients have disappeared. That group of people have now come back into general practice, but we're using the same acute, episodic, curative illness model to deal with them. You cannot deal with somebody with multiple comorbidities in 10-minute appointments. It just doesn't work. We've got to look at different ways of doing it. And when you think 90% of your health and well-being is delivered in primary care in the broadest sense. Now, this is everybody involved in primary. It's not just GPs. There's a hell of a lot of people involved in primary care. They deliver more and you have more contact with them. Why aren't we using this? Why don't we involve education? Why aren't we involving the economy? I mean, give somebody a job and you will reduce, if you take somebody out of poverty, you will reduce the chances of them becoming ill significantly. Why aren't we doing this?
So both of you have talked about the systems north and south, and neither is perfect. They're both suboptimal. But the outcome data in terms of morbidity, mortality, there is an opening, a widening gap now between north and south. People can expect to live longer in the Irish Republic with less illness in their middle age than is the case in the general population in Northern Ireland. So what's happening there? Systemically, why is the system in Northern Ireland seemingly underperforming to such a degree that it's now being described by many observers as the poorest performing system in these islands? It's the weakest of the 4 NHS regional health systems, the regional systems in effect, as opposed to a national health service in my view. But why is it that males, for example, in the Irish Republic in general can expect to live a healthy life for nearly 10 years longer than males in Northern Ireland? What's happening? What's going on underneath the bonnet, as it were?
Well, certainly in my experience, it is mostly poverty that is associated with the premature death. And you can see that. Certainly you can take the Majimsey bus route up the Lisburn Road. And as you moved up the Lisburn Road, you lived 6-7 years longer than somebody who lived at the bottom end of the Lisburn Road. And if you moved up further, it dropped again. If you come from a poor background, you die prematurely, often from preventable disease, often due to lifestyle. But poverty is at the essence of this. It really, and that's something we have to address. And this becomes generational. It passes down through the generations. And we miss a trick by not getting involved in education, where you can identify problems in families and try and move in, nip them in the bud before they happen. Now, I have not looked at the figures down south, and I'll take your word for it, but it would suggest to me that they must be healthier and wealthier than we are. Is that the case?
They have reserves of poverty, socioeconomic disadvantage, just as we have. I don't know the system well enough.
I don't know it at all.
And Mairead, you were in Dublin today.
So that stretch in the difference between outcomes north and south has changed, because I don't think it was that long ago that we had a look, maybe 5-10 years ago, and the outcomes were no different. And that surprised people because of the way you have to pay for some elements of your healthcare in the south. The natural assumption was that would stop people accessing it. But actually it wasn't changing the outcomes in any material way versus the Northern Irish system. But I think George is right. How long you live and how many years of good life you have, good health, is probably very little to do with your health and social care and more to do with your education, where you live, how you live, etc. But that doesn't mean that when you do become unwell, you don't need a first-class service to help you through that illness, or if it's a long-term illness, to support you through it. So your outcomes, yes, have some relationship to the health and social care that you can access. And I think George well knows that in some of the very poor areas of the practice that you served, people didn't make the right choices, or weren't informed enough to make the right choices, or weren't able to make the right choices about accessing healthcare.
Nobody volunteers to go into poverty.
No.
It's not a choice.
But I think your question is around, is the health service in the south doing something better than we are in the north? And certainly the hospital systems are under enormous pressure. I don't think the financial system and pressures are as dire in the south of Ireland. And certainly in our latest budget statement for health and social care in the north of Ireland, and our grant from the UK government, it looks as if we're going to have to make fairly swinging cuts right across the board.
450 million.
Yeah.
But isn't it interesting that on this small island we have two systems operating in a very different way, and we don't know a lot about how the other system works in detail, and nor, I assume, do they know how our system works in any great detail. And you've talked, Maria, about the need for greater synergistic frameworks. A start would be for more sharing of experience, sharing of knowledge, sharing of best practice. And then, perhaps, given that we're in the midst of a workforce crisis, not just in Northern Ireland, but in the Irish Republic, across the island, across these islands in the advanced industrialised world, it's a problem. So how you use the human resources, you have to use those smartly more now than ever. And we have assets that, you know, we have capital budgets that are very constrained in all jurisdictions. So what we have pre-built on the ground now should be used to maximum effect, surely for the benefit of all populations, and based on what is best in terms of location vis-a-vis where people are living.
Yeah, so I think George has made the point earlier that the vast majority of health and social care is delivered very locally by local practitioners and local workers on the ground. I think where we get into the synergy issue is where we are really struggling to keep services at the scale that's needed, the population scale that's needed to attract the best clinicians, to put a team of people together with all the skills that we need. And for some of our really specialist services, and I'll refer back to the paediatric cardiac surgery, which is now delivered for the island in Dublin, we just simply couldn't maintain that team in Belfast and in Dublin, but they're providing an excellent service coming together. So the majority of our services are very local. Border really doesn't come into it. But I think for our hospital services, where population size and catchment is important, then I think there's the opportunity for a real debate there as to where those hospital services are best delivered.
And is it coincidental that emergency general surgery has controversially been removed from Daisy Hill in Newry on the border, and now from Enniskillen on the border? Because in both cases, it's the half a hinterland issue that the population to the south of those relatively significant settlements, and South West Area Hospital is a relatively new, state-of-the-art facility, well equipped, and yet the population that it could service was constrained by the border.
But the bigger issue happening in that area is, in fact, the death of general practice. The fact that general practitioners are handing back their contracts, and that will have a more significant effect on the population than will have the loss of emergency surgery. So I think that is the area that we really have to look at. How can we improve that? How can we involve the population in their own health? Why aren't we doing that? I mean, to me that seems sensible. Why aren't we, look, lots of the illnesses we have, diabetes is preventable for the most part. Lots of the cancers are preventable to a degree as well. So there's lots of illnesses that can be dealt with, but we're not using all of the available resources that we have. And remember that Marmot was the guy who told 18% of your health and well-being comes from the health service. 18%. The other 80-odd, where do we get it from? We get it from all the schools, the education system, the justice system, the roads, the local councils, clean water, clean air. All of these things are happening in parallel lines. They're all investing, trying to get the same outcomes. Why aren't they all working together to try and deliver better outcomes for all of the population?
So if we stay in general practice, and when there's discussion in the media about the possibility of an All-Ireland National Health Service, the issue that's always raised is access to GPs and how that differs between North and South, and the fact that close to half the population in the Irish Republic have to pay for access. What's your vision of how GP services could be organised in a new system?
My vision of health system,
Well, share that with us, George.
it's universal. It should be paid out of taxation. It should be free at the point of need, not want. And its focus should be on preventing illness and interventions beforehand. We should invest in a health promotion, disease prevention. We should get the patients managing their own illnesses. A patient sometimes can manage their illnesses much better than their GP can and other physicians can. We should look at how we deal with CARES. We need to get integration into the system, and that I mean by vertical integration, where you can move from GP land, community, hospitals and down again, but also the horizontal integration, where education, employment, the local council are all involved in this. And I really do think we all should work for a single employer, share our resources and have an agreed vision of what we want to deliver. We can make better use of IT stuff at the present. I mean, we're sitting here in this system, this is going out on various media. Why aren't we using the same systems to try and get a message of health across to our population? I mean, if a pharma company can sell drugs to GPs using the fancy gear, why can't we use that to send a health message to our population? We're missing so many tricks which would make a considerable difference to the outcomes. So what we want something that's efficient, it's effective, it's responsive, and it delivers. And that's really what we have failed to do at present.
And having two so different systems that diverge to such a degree on this small island.
But do they diverge to such a degree?
In terms of practice, they do.
How do they? The GPs are there, the communities there, the hospitals are there. What's the difference? You may have to pay for the GPs. I read somewhere that they have passed an act or a paper come out from the government down there that by 2030 they intend to have a medical card for all of the population.
Yeah.
Well, that addresses the issue over payment for GPs.
No, my point isn't that. It's the fact that we have workforce shortages. It's accepted in both jurisdictions. So surely we need to make the best of the talent that we have within the health systems.
And what you have to do then is, I think it's crucially important that you have an effective team to deal with whatever, for example, strokes, cath labs for people with heart problems. You really have to people who see enough to hone their skills to end up delivering quality outcomes. And we have to look, what measurements do we use? We don't use any measures. We should look at outcomes. And this is an area where we really have to, I know you talked about centralisation and me being Belfast-centric. You mentioned that earlier on. But you've got to use the skills you have in the place that's going to give you the best outcome. And we all know this. I mean, this is a no-brainer. I mean, I was involved in a piece of work some time ago, and we found out after we had done the work that people just drove by this new service that we'd offered up to the Belfast centres. They marched in the streets to have the service, to keep it there. But when it was kept there, they drove by it. I mean, when if you get your BMW, do you go to the wee man around the corner to service it? No, you don't. You go to the people in the Boucher Road who know what they're doing.
I think the point that George is making is really important, because most of our health care, our health and social care, is locally delivered. We access it the way we access it. It doesn't take a lot of time and effort to get to your local GP or your local team. They're very stretched resource-wise, as everybody else is, but they're very local and known. I think when you need that next level of care through some specialist, then we get into significant difficulties, because everybody wants that specialist service in their local hospital. And the experience north and south is we just cannot provide the workforce to do so. And even if we could recruit the workforce, they actually want to retain their skills by operating or treating higher volumes of individual patients. So nobody will come, and you use the example of Daisy Hill, to work in Daisy Hill and provide emergency general surgery because they might only do it twice a week. Whereas if they go to a larger hospital, they can keep their skills very relevant. Now, your argument is, or the argument is, actually, but Daisy Hill could have twice its population if we took away the border. But there are also hospitals over the border who are probably having the same debate about their emergency general surgery and their ability to hold on to and keep it and not lose it to Dublin or other bigger hospitals. So I actually think the border matters in that the population either side of it is usually scattered and relatively scarce, and doesn't give that economy of scale or economy of population that's needed to keep some of these more complex services running in local hospitals.
But actually
unless we collaborate.
The exception is the East Border region, which is the most populous part of the island between Belfast and Dublin, and you have major centres, and you have Our Lady of Lourdes and Drogheda, and you have Craigavon Area Hospital. It's the very large population in between. And the argument is that partition has unnaturally divided that population. Mm-hmm. But beyond that, we're in the midst, and I think the argument is being accepted by most local populations now, that all hospitals can't deliver all services. It's been a battle in some communities to get that argument across, but people want to feel that they're getting treatment that is fair, and that treatment is equitable, and that people living in large cities aren't advantaged where they're disadvantaged living where they live. But that's a separate issue for another discussion. The challenge I observe is in Northern Ireland, for example, we have a significant disparity now in pay that is offered to consultants and doctors, nurses, home care workers, all levels of the health service. There's now a significant gap between those levels of pay and the pay that's offered in the Irish Republic. And this isn't, by the way, unique to the health sector. This is a problem now affecting the private sector, where talent is being hoovered up from Northern Ireland by employers in the South and the Irish Republic. And we are, in some sectors now, hemorrhaging talent across the border, and particularly on the East Coast, where it's easy to access. People can jump on a train, get down to Dublin, do their stint in Dublin and get back home and still live in Northern Ireland. So in that context, the argument is that we absolutely have to come up with a protocol, a framework to share limited staff resources, limited human resources to the benefit of all. Where we have two systems that are diverging in terms of how they approach the delivery of healthcare in one jurisdiction or another, on a small island, that's a problem. Would you agree? And where do you see the pathway for change in practical terms, Mairead first and then George, in terms of what we could do collaboratively on an all-island basis? Where do you see the scope for that will make a real difference in people's lives?
So if you took the politics out of it, and we talked about health and social care in its purest sense, any healthcare planner will tell you that in order to make the best use of your resources, you actually have to centralise those services which are most specialised and deliver the bulk of your services locally. So where does the border come into that, and where does those two different administrations come into that? So we don't only hemorrhage from Northern Ireland well-trained staff to the south of Ireland, we lose them to Australia, we lose them to the UK, and it's all to do with work-life balance, remuneration certainly. But the last thing I heard was it takes over £500,000 to train a junior doctor to become a consultant. So that's £500,000 that we put into the system. I'm sure it's no more now for every doctor that we train. And we may lose, 10-20% of them to other services. And that's probably a conservative estimate. So we put all of this time and money and effort into growing this workforce that we know, because of how we're asking them to work and how we're paying them, that they will see more attractive jobs and career prospects elsewhere. So why do doctors, nurses, etc., choose one job in the south over a job in the north? And it'll not just be about pay. It'll be about how they're expected to work, the team that's around them, how they're supported, how they're developed, and all of those other things. And I do think we are missing a trick, Conor, because unless we hold on to the people that we put huge resources, not just money. I mean, George's practice was a training practice forever. So they took in trainee GPs.
Well, could I press
blah, blah,
you,
blah.
Maria, just on one point, and you're a Bengoa expert panel member. Is it fair to say that the remit that you were given confined you to looking at restructuring of healthcare in Northern Ireland? And it's my understanding that similarly the Sláintecare review in the Republic has confined its review to exclusively to its jurisdiction. And there hasn't been, and wasn't in the case of Bengoa, or the reviews before that, Compton and Donaldson, they were Northern Ireland specific. And it's a very small region, geographic, whatever, take the politics out of it, it's geographically small, with a tiny population, 1.8 million, with a standalone public sector and a remaking of departments that would, in normal circumstances, exist only in large nation states. But that has to be remade from scratch in Northern Ireland because it's separated geographically from the rest of the UK, the Irish Sea, and politically from the Irish Republic. Yeah? So there is no history really of serious interaction between policymakers in the health systems north and south. Now, is that a fair critique?
It has been rare when it has happened. I mean, there's examples for cooperation and working together, COT, the cross-border body.
Public health issues.
Public health issues, there's a lot of collaboration.
Yeah.
Although in COVID now...
Part COVID at one side, but there's always been an all-round approach to public health. And a lot of interchange between the public health things. This discussion that we're having, and hopefully people outside listening will start part of the discussion, will generate people looking at what we can do differently, what we can do better, focused on outcomes for the populations we look after. Now, will this happen? I don't know, but I would hope that this will generate some sort of conversation to take place. And maybe others can come into this and look and see how we can do things better, because we're not doing things well at the moment.
And I think to your question, Conor, which is, do we need political support and permission to look at things in a different way and look at different populations? Yes, we absolutely do. Do we need structural and organisational change to start that? No, we don't. I think the thing that we have to do is to show that it would make a difference. George and I have both been through organisational change. Sometimes it's actually a barrier to improvement because everybody's so, obsessed about the new structures that they forget about the service change that's supposed to come alongside it.
And I agree.
Yeah.
In the case of the reform of public administration, the promised savings didn't materialise. It actually cost more.
Yeah.
I think the framework is one of, as you say, it's a very good way of putting it, permission. Permission to cooperate, permission to collaborate, permission to create synergies, that's a bit of protocol.
Yeah.
A much maligned term, but it is a bit of protocol, a framework, an agreement, a trade agreement, that the systems can collaborate freely.
But it has to be for mutual benefit. It can't be a win-lose situation, because I think that's how it's boiled down so many times, which is, well, if you get our services, that means we're losing them. But if we focus on the population that's going to gain from that change, and we sell the change to the population, and we say, actually, your health outcomes are going to be better, the outcome from your operation is going to be better because we're using an evidence-based team and a team of the right size and skills to make sure you have the best outcome from that operation that you possibly can be. That's something that I would choose.
Well, I'd like to thank you, Mairead and George, for giving your time this evening. I'd like to say to everybody out there, this is a crucial debate to have between yourselves, with others. Many people are sceptical, some people are more enthusiastic, but that we need to discuss change, however it's framed, within Northern Ireland on an all-island basis. That there is change needed, everybody seems to accept, because we are in the midst of a crisis. And it's a crisis not unique to Northern Ireland, it's a crisis, as I said earlier, across the advanced industrialised world. Systems vary, but there's a shortage of quality people doing the job. There's pressure on budgets, and demands from populations and expectations have grown exponentially. Our populations in the West are ageing. So join this debate. This is the key issue in terms of will there not be constitutional change? When will it happen? How will it happen? This is one of those practical issues that all people on doorsteps everywhere will say this is the issue that they want answers to. So everybody that has expertise, please contribute to this debate now and give your expertise. Be you a skeptic, be you for change, but contribute and be part of the discussion. So thank you for giving us your time, listening to us tonight, and thank you, Mairead, again, and George. Thanks.
Thank you, Conor.